The issue that I've talked to a number of physicians about this is that the healthcare industry as a whole right now is pushing doctors towards seeing more patients and spending less time with them. And also the introduction of the EMR systems have forced doctors to look away from the patient, to be sitting there typing on a computer doing data entry. And those two things cause the level of interaction, face-to-face interaction with the patient to go down. Everything that we've been talking about really involves, framing and nudging and things involve more time.
Mm-hmm.
So how would a physician balance those? How we know what we can do that would be more effective, but the problem is I actually have to spend less. I can only spend less time now with each patient.
Yeah.
So, is there a solution to that?
Well, yes, there are a couple of solutions, but they run into the same resistance that physicians do the same risk-averse personal behavior. I have to change the way I practice. I have to change my staffing pattern and so on. But as clinicians begin to function more and more as teams, then there are things where if you're in an organized large group practice or a healthcare organization like Kaiser Permanente or Group Health at Puget Sound or the Marshfield Clinic or any of the large, well-organized care organizations, you can say, okay, my patient is still smoking. I do know from the reports of the U.S. Preventive Services Task Force that from randomized clinical trials, if I simply say to my patient, smoking is bad for your heart and your lungs, and as your doctor, I'd really like you to quit smoking. States a simple fact, communicates your concern for your patient. As your doctor, I'd really like you to stop smoking. That 20-second intervention increases the probability of quitting by about 30 or 40% in randomized prospective clinical trials. Yet most doctors still are of the mindset that, well, nicotine is one of the most powerful addicting compounds we're exposed to, and I just don't have the time to talk to my patients about smoking. You have the time to give the 15-second statement and follow up with, if you're interested in quitting, we have this smoking cessation group that meets right here in our office setting 3 evenings a week or whatever it is. And I'm going to write down the information for you, or I'm going to give you this information. That's the way the time constraint can be handled about some of these behavior change issues. Or you can't expect every physician to be an expert at dietary counseling. When I went to medical school, the only nutrition instruction I received was what were the essential amino acids. We do a little better now today, but not much. So we're trying to encourage clinicians to think about the importance of dietary advice, but there hasn't yet been a prospective clinical trial that I'm aware of that tries to do for dietary advice what that smoking message did for smoking.
Really?
Yeah.
To me that sounds awfully crazy, because we know the deleterious effects of smoking, and we also know the same thing about diet.
Yeah.
But diet affects 100% of the population, whereas smoking affected a smaller percent.
Now, there's been a lot of research on whether or not physician advice does anything about our current obesity epidemic. But what I'm saying is is there a 15 or 20 second message that has the same motivating power as that one for smoking that will lead the patient with a nutrition problem? They're overweight, or they're eating too much meat, or they have type 2 diabetes and they're still drinking a liter of sugar-added cola every day. That's what, to the best of my knowledge, still is out there waiting for some courageous investigator to take on. And maybe it's not necessary because it is a very different situation. You have to eat 21 meals a week, and dietary patterns are so culture bound and so much a part of what Kelly Brownell at Duke University refers to as our toxic obesogenic environment that we all live in. The incredible marketing from junk food, processed food, sugar sweetened beverages, it's just everywhere.
We're being preyed upon.
Yeah, we are, absolutely. But here's the part that we haven't talked about yet, and it's a very interesting dilemma for clinicians. And that is that over the last 25 or 30 years, our understanding of the power of social determinants of health has just exploded. It started
Social
with...
determinants of health.
So by that I mean, how does education level, income, neighborhood conditions, the social environment, how does that influence our health status? And we know it does profoundly. But where does the individual clinician who looks at his patient, who maybe is working 2 jobs, neither of which pays minimum wage, or just pays minimum wage, not a livable wage, who is stressed out, still smoking, still eating comfort food, i.e. junk food, still drinking sugar-sweetened beverages. And all of that is a manifestation of the fact that they've grown up poor, not had a good education, live in a neighborhood that might be a food desert with no store selling healthy food, but lots of corner stores selling junk food. And as I said, it's really just been in the last 25 or 30 years that our true understanding of these connections has emerged. We've always had a sense, that people at the bottom of the income heap don't do as well as people at the top. But it was Michael Marmot, who's now actually Sir Michael Marmot, a British epidemiologist, who looked at the British civil servants in a series of studies called Whitehall, because Whitehall was where most of the civil servants in London actually work. And they have grades, as so many bureaucracies and businesses do. And he found that the people at the lowest grade were secondary school graduates, but no post-secondary school education. And they were kind of a makeup of the general British population. People in some of the middle grades were graduates of the so-called red brick universities, University of Manchester, Liverpool, and so forth. People at the very top were almost all from Oxford and Cambridge. And many of them had entered as management trainees at that upper level, and within a few years were actually at that pay grade. He observed that people going from bottom to top, fewer and fewer people were smokers, more and more people were eating better diets, more and more people were exercising regularly. Everybody had access to the National Health Service, so it wasn't a matter of problem obtaining medical care. He then used the statistical tool of regression, multiple regression analysis, to clear out the influence of excess smoking in the lower grades and poor diet and so forth. And he found after doing that that there was still an unexplained variance in health status measured by premature morbidity and mortality. With the higher up, the better off you are. He called it the social gradient in health. Hypothesized that it probably had something to do with self-efficacy, empowerment, but these are really
hard things to
hard
measure.
things to measure. So we haven't yet identified the neurotransmitter that might be present in greater amounts in people who have feel in control of their lives. And so the person at the bottom in Whitehall gets a decent salary for the work they do, has access to a quality health system, has a roof over their head, enough money to buy food, but they buy the wrong kind of food. And that person probably doesn't feel very much in control of their lives. They want to take a day off 3 weeks in the future. They might have to fill out some form in triplicate and wait for their supervisor to give them permission. The person at the top hears from a good friend that they're suddenly able to do something a week from Friday, and they'd really like him to participate or her to participate. And he or she says to their secretary, "Clear my calendar on the 14th, I'm going to be out of town." How does that then translate into better health?
Lower stress.
Lower stress, that's probably a big term.
Self-determination.
Yeah, but that's sort of, we're talking phenomenologically here. We still, I mean, the root biologic factor of the social determinants of health is something that I think we'll learn more about in the coming decades. But right now, what you're asking a clinician to do is the best thing you could do for your patients who are in the bottom quintile of US wage distribution is to vote for policy change